I'm Metropolitan Konstantinos. I live mostly in Singapore in South Asia. And as in my diocese, we run small clinics and also we run orphanages. Mostly, the majority of the children that we host in our projects are unwanted children or unwelcome children. Usually, some parents, when they learn that they born a sick child, yes, they throw this child in these areas. So we try to take all these children, and for me, it's very important to be involved in such this kind of events and conference because we can discuss and we can do not only the science but the ethical and um, all the alternative, yes, ways for all these very serious subjects. For this, please, we have Bertha, we have May.
Dimitris, why don't you start and then I'll
I
go
think
ahead. You
ladies
haven't
first.
spoken
I
yet.
think ladies first. Yes.
Oh,
Yes.
okay. All right. After that depressing but beautifully documented demographic futures that we saw, I think it's all the more important that genomic newborn screening be part of population health, if I can call it that, endeavors. Even if you take the province of Quebec, where I come from, we have a similar demographic situation. It's almost like a mirror copy. And at the same time, our population, even though it's declining, if there is growth, 40% of that growth are from other persons from other countries. And so a genomic screening program allows us to understand modern, heterogeneous societies, not the founder population or the isolates or all the other traditional ways of looking at monogenic genetics, if I can call it that. So it's really important to understand also the influence of the environment, because Eastern Quebec, the founder population, half of them have moved to urban Montreal modern in the last 50 years. So again, you can understand the past genetics by looking at the now genetics of those individuals to understand the influence of the environment on genes. So the more data that we have on actual heterogeneous modern societies, the better it is for healthcare systems. Second point, the newborn is not a patient. It's a newborn. It's a citizen. It's a newborn. It's not a patient. They're in a hospital setting because that's where they're born, but they're not sick. So we have to think of them, how can we optimize the future health for these citizens? And as you mentioned, forget where now, screening, oh, it was May, screening is not a diagnosis. We have to have confirmatory test and then yes or no, enter the healthcare system. But what I like best, and it's too bad I just see that Mimi has gone, rare will get us there, and genomic sequencing will find those rare conditions. But rare will only get us there, and I stopped there, rare will only get us there if we share. We must share data. And all this protection, controllers, processors, and all the other stuff of the GDPR, which has legitimate reasons for existing, but should not be harming the quality of the science. So whereas rare will get us there as we understand more and more about rare genetic conditions, which tells us a lot about common also, by the way, but only if we share. Therefore, we need to increase, not decrease, international data sharing, and in a secure way, in a safe way, but it can be done. And I don't think we should be frightened of all those Byzantine protectionist data rules that are meant for other legitimate reasons, but are harming true international data sharing.
Much, May.
Yeah, I feel like I couldn't say everything I want to say. Now I get a chance. Couple emphasize, again, from a public health newborn screening laboratory point of view. One is data storage reuse. I think it's quite important separate from clinical care and research. So we currently have the structure in place. If after newborn screening and you have health concern, we absolutely release dry blood spots. And I think we can use it the same way. But my concern is our other way around. Keep the data to the 20 years old, say, hey, what else we can see? So we need to be very, very careful. I'm a big believer. Think about harm and good and the net benefit when you make any decision. That's one of the things. Another one is, talk about data storage. I think we have a clinical testing regulation in place. We use a CAB or CLEAR, this rule, and we always use a 2+1. And I think Kevin said something I can relate it to. Your human body is the best storage DNA. And the technology involved, and you balance, you storage DNA, storage a large database. You talk about 66,000 per year, and our state have 60,000. The money you spend it, and maybe testing later, you have the better technology, everything. So I just want to emphasize this couple point. And don't let the perfect fall the enemy of the good. And we're trying so hard to make things perfect, but I think we need to start somewhere. And my philosophy is start more stringent and really think of public health. That's your goal. And other things are bonus, but not in that other way leading up.
Dimitris.
Thank you. Apologies, first of all, I'm very honored to be with you. Really, I don't think it's very rare that we have patient advocates, let's say, in events like this, and I'm really happy that I'm with you. Apologies I ran late. I had to train 20 patient experts for HTA, rare. So I am one of the owners of these unwanted children. So let's start by that one. But I decided to keep him because I like him. So my name is Dimitris Athanasiou. I run the Rare Disease Greece, and I also run the global organization for Duchenne. And I have in my home Hermes, who has Duchenne. I echo that sharing is caring, rare. This is very relevant. I also echo that we need to protect also and be very consistent on what's our story, because we are living in very strange periods. I would like to remind you the vaccines, the chips, the new fashions in various areas of the planet. So if we open one can, I don't say what's inside the can, right? It might be treasure, it can be a can of worms. We have to make sure that it will not be an excuse for reflection in the societies, for reflex that we don't want, because this will lead us to middle age. And you see that middle age is not very far, huh? It's always around the corner. Middle age with DNA can be a very dangerous game. Obviously, we need diagnosis, because 50% of our children are undiagnosed. 50% of our patients are undiagnosed. 500,000 people in Greece, 50% children, 50% are diagnosed. We lose 35% of them by 5. We need also a system of the unwanted, because when I took my diagnosis of my son, 13 months old, my first neurological professor told me, it's okay, forget about him, let's do another one. And my gynecologist said, it's very good that you are not emotionally connected with him because just 13 months old. And I said, fantastic, can I give him back? That was really the discussion we had. But my English wife didn't understand Greek by that time, so didn't understand what her gynecologist was saying. So yes, we need the screening, but you need a safety net. Because when these little feces that, as you said, the unwanted ones, pass through, the rare disease pass through the net. So you don't go to Crete, because the lack of accessibility and the lot of shame doesn't want the grandmother with a grandchild with a wheelchair to reach the village. Well, because Duchenne are very tough kids. They say, sorry, grandma, I cannot fly. But that's life. And this is the life we have to live with. So we need safety nets. So yes, let's do whatever testing. Genome, not genome, okay. What is afterwards? We heard about this fantastic genetic consulting. I would love to have genetic consulting. How many we have, Dimitris, in Greece? 10? So about 60,000 children, let's have 10 genetic consultants to do the consultation. And then when you go to the genetic consulting, they will tell you, don't worry. I know how you will not have a second child with Duchenne. Well, what you need at this moment is why some reason not to jump from the balcony. So most probably, you first need a psychologist, then you need a union that you have the other mad guys that kept these children to say, yeah, life is worth living with them. So you need a system, and then you need care. Standards of care, do you really want to discuss international standards of care? I know Duchenne in Canada, I know in the US, I know everywhere in 60 countries that we have organizations. Nobody follows the international standards of care because all our clinicians know better. So yes, let's make a plan when we don't have a net. It's not the diabetes which is going to fall out of the net. It's going to be our rare children. And I can tell you a real story also from Greece. We have 3 children, that's so rare, in a very small region in South Athens, that we have 3 children with Duchenne, same age. The difference is that my wife is a de novo mutation, and the mutation of my son is 1 child. No, we are 4 in the planet, so we're looking really good. The other ones that are genetic, they didn't have any consultation, so their mother jumped from the balconies. I tell you, they don't have the best life that these children deserve. So yes, we need the tools, but first of all, we need to think the system behind it. Are we ready to implement it? When we're ready, I will go for full genome. I don't care if you're going to take the news, if it is 1 day old, if it is in the belly, if it is 20, or if it is 200. But you have to have a system to support it. And just to close, and sorry for taking so long, just to be extremely clear, the data is from the one who the DNA is. And he's supposed to decide what he's doing with his data. If it is an infant, it's an infant. It's not his parent, and I'm a parent. If it is mine, it's mine. It's not for somebody to decide what to do to my data, and not somebody to say in the ethics level what I do with my child, because everybody is on the green side of the field. If you move to the other side of the field, I can tell you it's a very different story. Thank you.
That can work with spiritual children also. Thank you very much, our panelists. We have the privilege for 5 minutes to discuss. So, who will be the first to ask? Don't be shy. Yes, I'm coming.
Thank you. I would like to discuss with you the presentation of Professor May Baker, and 2 key points. The first point is that we do not report autosomal recessive disorders, and if I'm correct, in the newborn screening, we do not report autosomal recessive disorders.
Sorry if didn't make it clear. I talk about a carrier for autosomal.
Autosomal recessive carriers.
Yeah.
Yes, carrier. Yeah, yes, you are right about that. And the second is that we do not report variants of unknown significance.
Correct.
Yes.
Correct.
I would like to discuss with you a case of a child with epilepsy in the US, which was at the time diagnosed as having a variant of unknown significance. And later this child died of sudden death because this mutation was not variant of unknown significance, but later was stratified as a pathogenic variant. And the doctor was sued for $100,000, and the hospital paid $100,000. The second about the autosomal recessive carriers is that we may have an exception here, and the exception may be in isolated populations that we may have a higher concentration of carriers of the same disorder. So if we do this type of newborn screening in populations that may have cases of isolated populations, then perhaps we could report such data if we could help people from isolated populations.
Thank you. First, let me try to answer the carrier, the comments first. In general, conceptually, carrier for autosomal recessive condition should not have the health consequence. So as of now, newborn screening still emphasize for the infant, him or herself. When you talk about a certain population, they have a high concentrated certain carrier, I have a little bit difficulty connect that. What's the benefit? What's the intention? Just because the population has high frequency, we should report a carrier. So that's maybe. And the second part is more. Second question, the comments is more difficult, in terms based on the time we understand. If we're not clinically proved, it is disease cause. I think we're in the position we have to not report it. You think about it, if we start this gate, you do more harm than do good in the population level. And unfortunately, maybe we just do not understand what happened to the specific child. And this variance indeed is a lot of layer in that, have a direct connection. So only we learn more and we can improve more. It's why the next-gen sequencing give the form. You, based on the knowledge, you can always improve the panel, including more variants.
Thank you so much. Thank you so much. I think the last word belongs to Petros, and we would like to thank him for the beautiful idea to do all this tonight. Thank you so much. And first of all, yeah, we'll have to thank you, all of you, because yeah, you spent your time today to be all together, but it was for a wonderful idea and a wonderful event. Thank you.
Well, I need to thank all of you, the participants and the audience, for being here today. And what a feast for the mind. It was one of the most interesting and stimulating meetings that I have been. And the quality and the level of conversation was quite high. So my purpose here is to recapitulate what we heard. Okay? We started from the premise of newborn genomic screening and how this could be a link to precision medicine. We moved into how data are governed, data governance. Then we had a tour de force on innovation and how we can innovate, particularly in places that are smaller and more contained. And the end was on public health. What are the basic principles of public health. So I don't think there is any question that population screening is useful. And there is no question that population screening can save lives. However, screening is risk stratification, is not diagnosis. So that's number one. What it means is that we identify a group that is at a higher risk of developing disease. And as I'm fond in saying, we want to treat people disease. We don't want to fix mutations. So as someone who recently celebrated my 50th year since I graduated from medical school, what I have learned is that when you do screening, you need to establish two fundamental parameters: negative predictive value and positive predictive value. Okay? To me, as a physician, negative predictive value is quite critical. I don't want to miss someone who might develop disease. Positive predictive value is extremely important, but there's a fallback. So newborn genomic screening at this point is a research activity and will remain a research activity until we get to the point where we can establish the negative and positive predictive value of pathogenic variants in specific populations. So populations are not homogeneous. Populations move, gene frequencies change, and the nature of mutation is different. So our colleague here, Professor Georgiou, asked the critical question, okay, VUS. What is a variant of uncertain significance in a given database? Might be a pathogenic variant in a different population. And there's a difference between screen positive and screen negative. So if it is a screen positive and you confirm it, you need to treat it. If it is a screen negative, at the very most you can do is you just follow it up. So until we get to that point, we cannot credibly introduce newborn genomic screening as a tool to screen populations. Not only in Greece, everywhere. Okay? And that's why there are now at least 20, 25 initiatives that are enrolling babies as part of a research study into studying that exactly problem. Now, as I said before, in order for screening to be successful, we need to have cross-border collaboration. Maria said it. The data are there. We simply don't have ways or methods to access them and evaluate them in the context of a particular population. And I think this is how this is going to happen. The faster we do it, the better it's going to be. So that's one problem. The second challenge is all this nexus of ethical and other legal concerns. There's no question that if you have information to the genome of an individual, this is important information. And of course, rightly so, people need to be reassured that the information is protected and it's not an open field for whoever wants to get there. And however, we need to keep in mind why we do screening or genomic screening. We do screening for two reasons. First of all, we do screening because we screen for treatable disease. Okay? It's not an exercise in curiosity to find genomic variation. Okay? These are population studies. The Genome of Europe does it, reference populations. But if we're doing public health screening, we do it because we want to identify treatable disease. And that's one part. The other part is we always need to keep in mind that out of the 10,000, give or take, genetic diseases, only a small fraction have a treatment, and probably around 10%. So we have a unique opportunity by collecting this information and, of course, managing it responsibly to find therapies for the other 90% of genetic diseases for which there is no treatment. So let's not get carried away about all these regulatory and ethical concerns about how to overprotect the data. We need to protect the data. There's no question about it. But then let's also view it as to how we can be flexible to have the ability and the tools to develop new treatments for diseases that are not treatable at this point. And I would like to actually end this by saying that we need to create sustainable ecosystems. There is not a single actor who will come up with an answer on this. We need to have several components in place. We need to have international collaboration. We need to have a robust legal framework. Okay. We need the collaboration of the public sector. We need the collaboration of the private sector. They are the ones who will develop drugs for the kids that need treatment. So this is an entirely new field, and it's a nascent field. This is happening, or at least has been evolving for the last 5 to 7 years. And we need to be brave, and we need to be imaginative, and we need to be innovative, so that the end point is what he said, and I'm pointing because what he said was very touching. What Terry said is very touching, okay? He is the owner of a son who has Duchenne muscular dystrophy, okay? And we need to be cognizant of that there are parents out there who have children, and the answer, oh, take him home and love him, is not good enough, okay? There needs to...
That is not treatable, so maybe we can see the actionable also,
Yeah.
because Duchenne will not be in your screening program, just to say.
Dimitri is,
Have a
yes.
second one.
I'm not going to give you a recommendation what to do, you and your wife, okay? So it's,
The Wilson,
yeah,
the criteria.
it's beyond my remit. It's beyond my remit. But anyway, that is how I would like to end. And again, thank all of you for your active participation. And I would be remiss if I would not thank Illumina, who has underwritten this conference, this wonderful conference. It was a feast of the mind, and it's an eclectic group, but we view it as a think tank. Here are people. It gave us an opportunity to think and reflect and go back and do something about it. So have a good night.
Very much. Also a big thank to Hellenic American Union here that host us, and have a great night to all.